Hello, my name is Professor Sinclair. I'm a neurology consultant at the University Hospital, Birmingham. I also work as the Chief Scientific Officer for Invex Therapeutics. In my capacity as a doctor and as an academic researcher, I have built one of the largest clinics for idiopathic intracranial hypertension in the world. It's a condition that's very close to my heart. I started studying idiopathic intracranial hypertension over a decade ago. There was a patient that I saw in very early days that really struck my junior career. She was a young lady who had presented to the neurologists at the weekend on a Friday with tremendous headaches that necessitated her to go to hospital. She had found that her vision was becoming blurred and starting to black out. She was scanned and her brain scan was normal, and she was left to be seen by the neurologists on the Monday morning. And by the Monday morning when I arrived, this poor young lady could only count the fingers in front of her eyes because her vision had declined so markedly over the weekend. She was very frightened, and we went on to do a lumbar puncture and saw that her brain pressure was very high. And from there we had seen that she had idiopathic intracranial hypertension, a very devastating condition for young, usually obese women of childbearing age. So that's the age between puberty typically and menopause. And for these women that present usually with headaches and then visual loss, it's a very, very frightening experience, but also a very dangerous condition for them, because as you could hear from that lady's story, they can lose vision very rapidly, and some of them will lose vision more slowly. But for many patients, actually, this is a condition of chronic, long-term headaches. And the patients will find that those headaches are so severe that they can come every day. They can be very, very, very intense, at 10 out of 10 severity. And that will mean that normal activities that you or I would do, for example, taking the kids to school, holding down a job, looking after the home, become absolutely untenable for these patients. And I work very closely with the patient charity IIH UK to try and really put that message out now that patients suffering with idiopathic intracranial hypertension is really important to address. And I'm pleased to say that over the last decade or so, we are starting to make steps forward. It's not been an easy progress with this condition. We've known about it for over 100 years. It was actually first described in polar explorers who ate excessive polar bear and seal liver, and this gave them a hypervitamin A levels in their blood, and they produced a condition a bit like idiopathic intracranial hypertension. But it was some years later that the traditional condition that we call idiopathic intracranial hypertension began to be described in earnest. And we've known about this condition now a very long time, but we've not had straightforward ways to treat because we haven't had availability of good treatments. But the progress that we've made over the last 10 years has really been to unify a lot of the scientific community and clinical community. One of the key documents was the International Consensus Guidelines that we published in 2018 in the JNNP journal. And this has laid the framework for how standardized care hypertension. We now have very standardized techniques for making the diagnosis, for very straightforward ways of taking the patients through that pathway from where they present to getting that diagnostic label. And thereafter, we need to get them on a treatment pathway. Now, these patients are typically overweight, so we do try and talk about losing weight and facilitating weight loss. But of course, that's notoriously difficult to achieve and then to maintain in the long term. And the literature is very clear that where weight loss comes down, the condition can get a bit better. But certainly if weight goes up again, the condition can decline again. And we have many patients who show relapses and remissions over decades with their IIH, and certainly many patients that have significant deteriorations. We don't have good treatments for them. The main tablet that we use off-label is acetazolamide. One of the earlier randomized control trials of that drug really highlighted the main problem, and that's intolerability. So in that trial by Ball et al., we saw that over 48% of patients had to discontinue that drug in that trial because it was intolerable to them. And when I mean intolerable, what I mean is that the drug really gives the patients, it gives them horrible tingling and taste in their mouth. It can give them depression and profound nausea. So it's very unpopular for many patients to take at the doses that we need to control brain pressure. But there are no other licensed drugs. There are no licensed drugs at all for IIH, and we have a great need to develop therapies because, as I was saying, we don't have an adequate way of controlling the disease. Unfortunately, for those poor patients that do continue to decline, at the moment we have to resort to very invasive neurosurgery. So This would often be called a CSF shunt procedure, which is where a tube is put into the ventricle into the brain and then drained into the abdominal cavity to relieve the brain pressure. But this is not a straightforward procedure. Of course, it's a brain procedure, so it has inherent risks and side effects, but also a real rate of failure. And so the data shows that 30 to 50% of shunts will fail within the first year. They can get infected, which can give you like a meningitis. They can get blocked. They can disconnect. And for many patients, they can actually drain too much, which can then give them further problems of increased headaches again. So they're a very difficult procedure to put onto the patient, because it usually means for many, many years then they'll be going through multiple neurosurgical procedures. So what we need is a way forward to provide a drug that is licensed, that is tolerable and has very low side effects, and that will be efficacious and work to reduce brain pressure. So work began in my lab a decade ago, where we started to really focus on the mechanisms of how brain pressure is controlled and how we can try to manipulate the amount of brain fluid produced, because if we can reduce the amount of brain fluid we produce, we can reduce the brain pressure. And we started off our work with a publication in Science of Translational Medicine in 2017, which showed very clearly that a new class of drugs could, well, an old class of drugs could be used for a new effect. And we saw these old drugs that we've known about for a long time had another use, and that use was to reduce the secretion of brain fluid. And we showed that in animal models, this could dramatically reduce brain pressure. And that was actually a big reduction in brain pressure. We tested some of the other off-label drugs we occasionally use. They had either no effect on brain pressure or a very minimal effect. But the effect with the GLP-1 receptor agonists, which we were looking at, had a marked effect at reducing brain pressure in the rodent population to around 43 to 45%. And that we could do that even when the rats had profoundly high brain pressure. We were able to double their brain pressure and make them unwell with the high brain pressure, and then show we could reduce it with the drug. So from there, we needed to take our preclinical studies through into humans. And over the last couple of years, we've been setting about how to do that in the population of patients with idiopathic intracranial hypertension. And I have to say the community is really excited about this, both from the clinical side, the academic side, and the patient community. We've got tremendous support because of the need to bring through new drugs. And we've had many patients contacting us to be involved in our studies. And although it's only been a UK study so far, it's been very interesting to see the reaching out I've had from around the world, American patients from Australia contacting to say could they be involved in the research. But that particular study at that time was a very much a phase 2 early trial, where we needed to show that we could reduce brain pressure in the patient population. And we did that in a sophisticated way, because we needed to measure brain pressure very accurately. So we were able to use some new technology, which is the gold standard for measuring brain pressure. It involved a little operation to put a brain pressure probe through the skull and into the brain tissue, so that we could measure brain pressure every second, beat to beat. And we were able to give the drug, monitor the brain pressure at 2.5 hours when the drug reaches its maximum levels, monitor the brain pressure again the next morning at 24 hours, and then monitor out at 12 weeks, having dosed the patients every day. So we had 3 time points, which were our primary outcome measures, and we were really pleased to see that at every time point we had a significant reduction in intracranial pressure. So we could reduce the brain pressure very quickly, but also over the long term. So that study's had a tremendous impact on the academic community and also the patient community. We're really excited now to be able to bring that forward and into a phase 3 trial, which we're really pleased that Invex Therapeutics will supply the vehicle and the phase 3 trial to do that. So IIH, just going back to think about why we need new drugs to come through, I've highlighted that there's a lack of drugs. But I think the other thing to talk about with IIH is that this used to be a condition a bit like a sort of a Cinderella specialty within our neurology topics, because we didn't have a drug to treat it, and patients didn't get much time or acknowledgement from their physicians because there was new drugs and because there wasn't a drug. So what we have seen is the growing problems, because more and more patients are now presenting with IIH. If you look at the data from large epidemiology studies, back 10, 15 years ago, we used to call this condition rare at a rate of about 2 per 100,000 or 1 per 100,000 in some communities. But the data is very clear now, and what we've seen is that there is an exponential increase in the incidence of IIH over the last 10 years. So the incidence is nearer 5 per 100,000, but in the female population, about 9 per 100,000. And this marked increase in incidence is tracking with the global epidemic of obesity. And I think that that observation is incredibly important, because we see now that BMI matches very, very closely with the incidence rates. So the incidence of IIH is kind of flat until you get to a BMI of 30, and then the graph goes right up with increasing BMI. And that data is from the paper in JAMA Neurology last year. So what that means is that in countries where we have, or parts of the country where there are higher BMI, we have higher incidence of IIH. And this is having a huge impact on the patient population, but also on the provision of healthcare services, because it's a very costly condition. These patients have frequent readmissions to hospital with crises due to headaches, and needing their ICP managing, and needing their vision checking. So there's very frequent attendances at hospitals with lumbar punctures and scans, which makes this a huge health economic burden on the countries and the populations where there's high BMI. So we have the need for the patients, and the need also for the healthcare providers that we have an effective drug to come through for IIH. I think over the next few years, it's going to be probably some of the most exciting years that I've seen in my career for IIH. We have made progress in terms of the consensus criteria. We have made progress in terms of trying to understand why we get this condition, and we have some really interesting research coming through looking at the androgen excess profile. That's a hormone excess profile which may be underpinning the condition. But by far and away, the patients are clamouring and calling out for new treatments, particularly that will address the problems that they have with headache, but also mitigate the brain pressure and the vision problems. And the ability now to bring through the GLP-1 receptor agonist drugs in the form of Crescendin, which is the reformulated GLP-1 receptor agonist, so that they can use that drug as a once-daily injection in a clinical trial that will hopefully look to license the drug at the end, will be a very powerful and important tool for the patient community, and certainly being talked about also in the academic and clinical community.